name is Nina Southworth. I'm Support and Information Manager at SRUK, and I'm delighted to welcome you all to today's webinar, and a big thank you to everyone who's registered. Today's webinar is on localised scleroderma in its many forms with Dr. Cate Orteu from the Royal Free Hospital. I'll be introducing Cate a little bit more in a minute, but first of all, some housekeeping rules. Dr. Orteu will first give a presentation, and then you'll have the opportunity to have your questions answered. So you can do this by clicking on the Q&A function at the bottom of your screen, and we will get to those at the end. Do bear in mind it's a public forum, so please keep your questions general and not too personal. We'll also be recording this webinar, and it will be published on YouTube, and we'll send you all out a link afterwards. So now it gives me great pleasure to introduce Dr. Cate Orteu to you all today. Dr. Orteu is a consultant dermatologist who has worked closely with patients with scleroderma for many years, alongside Dr. Chris Denton and the scleroderma specialists at the Royal Free, running a nationwide scleroderma clinic. Dr. Orteu lectures on localised scleroderma to many healthcare professionals in the UK and abroad. She's contributed to the SRUK publication Understanding Localised Scleroderma, which is available to download on our website. You can also order a free physical copy by emailing or phoning our office. So, thank you very much to Dr. Orteu for agreeing to talk with us today, and I'll be handing over to you now.
Thank you very much, Nina, and thank you very much to SRUK for asking me to give this talk. I'm going to share my screen and hope that this works. Here we go. There we are. Is that? Can you see that as it should be?
All good.
Great. So what I'm going to talk about today is Morphoea, and you can see already that there are various different terms used to describe or interchangeably with Morphoea. In the US, it's spelt without an O. In the UK, it's spelt with an O. And in the literature and amongst rheumatologists, it's very frequently referred to as localized scleroderma. So in my talk today, I hope I'm going to help you to understand how these terms actually, what these terms actually refer to, and some of the other terms used in sclerotic skin diseases. The differences between Morphoea and systemic sclerosis and how you can identify those. The different subtypes of Morphoea and how we assess Morphoea. In particular, what's active, what's not active disease, and how we decide mild from severe disease, and then a little bit about how we treat this condition. So those are my disclosures, none of which are relevant, I think, really to this talk. So if we think about the terminology first of all, so scleroderma comes from the Greek skleros and derma, meaning tight skin. And it's really an umbrella term which encompasses a number of different conditions, including systemic sclerosis and Morphoea. So if we go to systemic sclerosis, first of all, so this is also sometimes referred to as systemic scleroderma. And historically, it has been divided into limited and diffuse systemic sclerosis based on the extent of skin disease. So in the limited disease, involvement is of the extremities, so tight, thick skin involving the extremities and the head and neck. Whereas in diffuse disease, it is much more generalized and can potentially be whole body. Thankfully, over the last 30 years, we've made some progress in terms of classification. And so now this, the skin distribution is sort of supplemented, if you like, by the autoantibody profile and also by molecular messages, if you like, from skin biopsies. And so we can be a little bit more directed and precise in terms of classification and risk of internal organ complications and prognosis. So that there has been significant change, but in terms of the terminology, that hasn't really followed on. And so we're still talking about limited and diffuse disease. And then qualifying it. And part of the issue, I think, here for me is that not infrequently I am referred patients with a diagnosis of limited scleroderma. And so in that situation, it's sometimes quite difficult, both for me and for the patient, to know whether the person who has made that diagnosis meant limited systemic sclerosis, which is a condition which involves internal organs, or whether they actually meant limited, or rather, sorry, localized scleroderma, not limited scleroderma, and therefore Morphoea, which is largely a disease which doesn't involve internal organs. So terminology is important, and so I would encourage, and I always encourage the doctors that I'm teaching to use the term systemic sclerosis and Morphoea rather than scleroderma, because I think it's easier for people to know exactly what you're talking about. Part of the issue also is that when you look up scleroderma online, there's very little on Morphoea, and a lot of the patients who come to see me often have looked online and are really worried that they've got a systemic disease which will involve internal organs, including their liver, their kidneys, lungs, and heart. And of course, generally speaking, that is not the case with Morphoea. So Morphoea can be subdivided into a number of different types. So linear and band-like disease, more limited oval plaques, patients with what is sometimes referred to as generalized disease in the literature, but which I prefer again to refer to as disseminated plaque disease, again, because it's clearer what you mean. Because in the literature, generalized Morphoea can also refer to patients with pansclerotic disease, which is more severe and circumferential. And I'll show you some examples of this going forward. But I'm just going to go back a little bit again to systemic sclerosis, and just to say Morphoea is not systemic sclerosis. So we do not see the same skin signs as we do in patients with systemic sclerosis. So these are examples of the skin changes we see in systemic sclerosis, not in Morphoea. So patients can present with puffy fingers as one of their early manifestations, and this gradually, the skin becomes thickened, tight, bound down and onto the fingers and the backs of the hands, and then this can subsequently extend further up the limbs and onto the trunk. So sclerodactyly, digital ischemia and digital ulcers, again, so patients with Morphoea may get Raynaud's, but they do not get the same vasculopathy changes as patients with systemic sclerosis. And so we do not see calcinosis, we don't see digital gangrene as the sort of most extreme type of digital ischemia, and we don't really see digital ulcers, although we do sometimes see ulcers elsewhere on the skin. In terms of pigmentary change, dyspigmentation, so darkening of the skin, is a really common feature of active systemic sclerosis, and so patients can look really tanned when in fact they haven't been anywhere near the sun. There's also something called a salt and pepper dyspigmentation, where you get this sort of mottled change. Patients present with facial features in systemic sclerosis, so thinning of the lips, thinning of the nasal bridge, and lots of dilated blood vessels known as telangiectasies, which can happen on the face, on the chest, neck, hands, and in a more widespread way. But those tend to be the commonest places. And it's pretty rare to get oral aperture changes, i.e. so in systemic sclerosis, it becomes more difficult. The skin tightening around your mouth makes it more difficult to open the mouth wide, and also makes it more difficult to stick your tongue out further, because the frenulum at the bottom of the tongue gets sort of stuck and bound down too. So in Morphoea, we tend to see involvement of the neck and jawline, but it's actually quite uncommon to see that circumferential perioral change around the mouth. So as I mentioned, we do see Raynaud's in a proportion of patients with Morphoea, but Raynaud's is common in the adult female population as a whole. And so this is an example. This is one of Kevin Howell's images, who does all our thermography at the Royal Free. So this is somebody who's dunked their hands in cold water for 5 minutes, ice cold water, I might add, and is very slow to rewarm. So the rest of them is these are the sort of warmer temperatures, and blue is cold, and so their hands have stayed very blue. What we don't see in Morphoea is this is the blood vessels at the nail fold capillaries, so the proximal nail folds. And these become abnormal in systemic sclerosis, but they remain normal in Morphoea. We also do not, as I mentioned, see the complications of systemic sclerosis in terms of internal organ involvement. So we don't see the gut complications that are identified in systemic sclerosis. We don't get pulmonary fibrosis or pulmonary arterial hypertension, and patients don't get renal or heart disease. So, and I thank Professor Denton for this slide. So there is a difference in terms of the risks and complications between Morphoea and systemic sclerosis. So what is Morphoea then? Morphoea encompasses a group of related conditions which are characterized by varying degrees of skin thickening and fibrosis, and then subsequently skin thinning. And it can involve the skin, the underlying subcutaneous tissues, so the fat, and sometimes can extend more deeply into the fascia, the muscle, and on the head and neck, in a smaller proportion of patients, it can involve bone, eye, and brain. It's very much a female predominant disease. So the ratios vary between 7 and 2.6 to 1. Overall, it's probably about 3 to 1. It's slightly less female predominant in children. It's a rare condition, so there isn't a mass of epidemiological information out there, but one of the key studies was a population-based study which was published by Peterson in 1997, which looked at the population around the Mayo Clinic and then picked out the numbers of patients with Morphoea within that population, and they identified between so it was 0.4 to 2.7 per 100,000 per year was the incidence. So those figures up here are just translated to millions. And they worked out a prevalence, so within the population, a prevalence of between 5 and 22 people per 10,000 population had Morphoea, and that varied based on age. So in the younger age groups, it was 5, and in the over 80s, it was 22. So that was quite a landmark study, but actually when we looked at it out of that local population, there were only 82 cases of patients with Morphoea, so it still overall is quite a small study. There is a UK and Irish children's study which was undertaken by Ariane Herrick, who has spoken for SR UK on many occasions that I know of. And that suggested an incidence of 3.4 children per million per year developing Morphoea. And then there is a very much more recent, so that was 2010 roughly, and then in the last couple of years there is a publication from the US which looked at insurance registrations and identified a higher prevalence, so quite a high prevalence again of sort of 3.2 to 3.6 per 10,000 children in the population had Morphoea or had a diagnosis of Morphoea listed. So it's rare, but it's not that rare actually. Oh, sorry. And so we do need to be aware of this condition, this group of conditions, and doctors don't see it as often as they see things like eczema and psoriasis, obviously, and so there is a delay in recognition quite often. It begins, there are 2 peaks of incidence. So there's a sort of peak of onset in children around the age of 7 and 8, and then there's another peak of incidence in adults in their 40s and 50s. And the type of Morphoea is different in adults compared to children in terms of the most common forms of Morphoea. And in adults, we tend to see more plaque disease and more generalized, so disseminated plaque disease, and less linear disease. Whereas in children, a majority have linear disease, so band-like involvement of a limb or of the head and neck or of the trunk, and a slightly, overall in studies in children, there is a sort of an incidence of about 15 to 23% actually have what's called a mixed pattern of Morphoea. So they may have a combination, or the commonest combination is linear and plaque Morphoea. So that's not uncommon. So what does it look like? So if we think about the different phases of Morphoea, so this would be number 1. So in the early stages, we tend to see a redness or a sort of purplish bruise-like discoloration almost. And then as it progresses, often the skin becomes shiny, white, thickened, waxy, and you may well see redness, so we call it a lilac ring. In this case, it's beginning to get a bit darker. Sometimes it can be a lot redder. So a red or purplish edge, which generally means that it is active. And here you can also see what we call peau d'orange. You can see that it's a bit like orange skin. You can see the pores quite prominently, and that reflects edema or swelling in the skin. So all of that looks active, and then as time goes on and it becomes less active, we tend to see brownish pigmentation most commonly. Occasionally it's pale, but usually, certainly in my experience, although publications are not, there aren't many publications on what proportion of patients develop pigmentation rather than pallor. But yeah, so brownish, and again, and then it becomes slightly thinner often, and that's a sort of damage phase. So brown and so hyperpigmented and atrophic, so slightly thinned, and you may see a dip, and you can sort of just about get it there. It's not so easy to portray in pictures. So this is the histology, just as a dermatologist, I can't do a talk without showing something under the microscope. So anyway, this is the top of the skin, the epidermis, which is usually pretty normal, but the skin is expanded. So the dermis is expanded, it's thickened. It's normally in a punch biopsy like this, we would see in normal skin, you would get a sort of wasting, as in, so an indentation here, but in Morphoea and systemic sclerosis, it's a sort of square shape because of the expansion of all this collagen. And that can carry on, that can expand further down into the subcutaneous as it is here. So that's the fat, and it's going down and into the fat and beyond in this particular case. And there's also a little bit of inflammation. These little dark dots are inflammatory cells in the top bit of the dermis. Moving on to the types of Morphoea. So in limited plaque disease, you just see one or two oval plaques, which will look similar to the ones that I have shown you thus far. In disseminated plaque diseases, which I guess you can also be referred to as generalized plaque Morphoea. This is the occurrence of multiple lesions. So patients have 3 or more plaques which may become confluent, and they need to occur at least 2 anatomical sites for it to be classified as generalized or disseminated plaque Morphoea. Those anatomical sites there are 7, so there's 4 limbs, a front and back of the trunk, and then a head and neck. So if you have lesions at more than, or at least 2, but generally more than 2 sites, then that would be classified as disseminated plaque disease. And there are 2 main patterns of this, as illustrated here. So this is a symmetrical pattern which is occurring on the limbs, trunk, and can be quite widespread. And this tends to happen in a younger age group, and the Morphoea lesions are often slightly deeper and thicker, and it can be a little bit more severe. Whereas this pattern is known as isomorphic, and so you can see this. This is a side view of the trunk, and this lady has plaques of Morphoea which are in the bra line and also around the waistband, and generally we see them extending down into the groins as well. So they occur at sites of low level pressure from clothing, and that's something which, so it's thought that pressure is a trigger for the development of the lesions. And this tends to happen most commonly in perimenopausal and postmenopausal ladies, and it usually is more superficial. So it's less common for this pattern of disease to cause deep involvement. Pansclerotic Morphoea is So these are some images here. So this is the most severe type of Morphoea, really, and the one which is most difficult sometimes to distinguish from systemic sclerosis when patients are progressing rapidly in the early stages. The key, so this is circumferential involvement. So you can see this patient has got shiny, tight, thickened skin all over his abdomen and across his chest, and it's the skin creases are no longer evident. And it all looks sort of like a tight, shiny drum, and that's often how it feels for patients as well. It generally tends to spare the area around the nipple, both in men and women, and that's a kind of reproducible feature. It can involve the limbs, and this often it's very tight and bound down around the lower legs, and can stop proper normal ankle movements and reduce flexion extension at the knees and hips. In involvement in the upper limbs, sometimes you see a sort of puckering around this area particularly, and the other thing that is really important is that the hands, the fingers are spared. So the fingers and toes are spared. The head and neck are less often involved, although the neck certainly can be. But it's rare, and you certainly don't get the features of narrowing of the nasal bridge that is seen in systemic sclerosis. So those are key differences between systemic sclerosis. So that lack of involvement of the fingers and lack of facial changes. But it is quite a severe condition, and it needs to be picked up and treated as early as possible, really. Thinking about linear disease, so linear disease can involve the head and neck, so it's sort of subdivided into head and neck and trunk and limb varieties. In the head and neck, we get the classical en coup de sabre, which is like a saber cut on the forehead, and this can extend into onto the scalp and cause hair loss, which can be reversible with treatment, but often becomes irreversible with time. It can also involve the lower half of the face, and also sometimes the area around the zygoma, so across the cheek and jawline, and sometimes involve the whole half face. In a majority of our cases, the skin is there's a dip and there is a change in pigmentation, but it's not as common to see the sort of shiny, thickened plaques that we see here on the head and neck. It does happen, but a majority of cases, I would say, tend to bypass that phase on the head and neck, or not show it at all. Sometimes you get a small area of sclerosis, and then the rest is just atrophic and dipped. In terms of the limb lesions, these are often linear bands, and I hope you can see this because at the moment my image is blocking it. But so you've got a shiny white or yellowish sclerotic band with surrounding redness, and it's happening in a linear way, going in a band along the back of the arm. Similarly here, this is slightly deeper involvement, and you can see there's more of a dip, and it's also a later stage of disease on the thigh, and then in some cases particularly of childhood onset, but you also do see changes in terms of girth of the limb in adult onset disease sometimes. So this, when you get deep involvement and extensive involvement, you can get this sort of appearance with reduced muscle bulk and soft tissues over both the sort of upper and lower limb. So most forms of linear morphea are thought to follow something called Blaschko's lines, and Blaschko's lines are thought to represent pathways along which skin cells move and proliferate during fetal development, so in utero. The group at Great Ormond Street published this a while back now, and the pattern of involvement is very similar, so it's reproducible. So patients present with this line on the forehead and this area on the chin, as I showed you in those clinical photographs, Similarly, these two lines are well recognized, and the Gosh team took photographs of all their patients and then basically went over them with a computer program and matched them to Blaschko's lines, and they mirrored Blaschko's lines. So in black you've got Blaschko's lines, and in red you've got the patterns of Morphoea of multiple patients superimposed on I guess a dummy image. So you can see this shows some of the truncal lesions again, which are Blaschkoid. So linear disease of the trunk tends to occur in this sort of pattern. You can get plaque disease on the trunk as well, which doesn't tend to follow the same distribution. So we've talked about the fact that you can get limited disseminated plaque disease, pansclerotic circumferential involvement, and linear head and neck or trunk and limb. We've talked about the different patterns of disseminated plaque disease. So this isomorphic pattern happening in middle-aged ladies predominantly, and the non-isomorphic symmetrical pattern happening in younger adults. There is also something called lichen sclerosis, which overlaps, and I will talk about that again in a minute. Mixed Morphoea is more than 2 subtypes. And then the other important kind of modifiers and qualifiers really are whether or not there is superficial disease or deep involvement, and whether or not it is active, or whether or not it's in a sort of damaged late stage. So these will determine how we approach the condition and how we might manage it as a medical, from a medical perspective. So just to again illustrate the superficial versus deep. So this is superficial disease. It's involving the superficial part of the dermis. There's not much in the way of puckering going on, there's no sort of obvious tissue loss. Here it's involving the deeper dermis and the subcutaneous fat, and you can see that there is some quite significant tethering going on. If it goes deeper and involves the fascia, which is sort of the coatings around muscles, it can cause a puckered appearance, and you also get this classic what's called a groove sign. So you can see here you've got a groove along the line of vessels, blood vessels. So that's a very typical sign of sort of deep involvement. And then if it involves muscle and bone, this is, as you can see here in this chap's forehead, you can really see that there is an area of sort of a dip. In terms of activity, so if it's red and a bit swollen in the early stages, the shiny bruise-like with a slightly red rim. This is a more inflammatory red border, and it's shiny and waxy centrally. So all of these are really active lesions, whereas as time goes on, you might still have some thickening and waxy change, particularly centrally, but the edges become hyperpigmented and brown. And then subsequently, you may get sort of thinning of the skin and the pigmentation, and then the blood vessels become more visible through the skin, and you can see a difference between the normal skin here and then the skin which has got damaged by Morphoea. So local complications. In linear disease, it crosses joints or involves the head and neck. As I've shown you in some of those images, you can get limb asymmetry, particularly with adult involvement and onset disease. If you start to get Morphoea as a child, it can also alter the growth of a limb if it's on a limb, and if it goes across joints, it can affect the joints. In patients with widespread disease, you can get joint contractures, and in patients with linear disease crossing joints, you can get joint contractures. And more recently, it has become apparent that you can also get an associated arthritis, which may be at the site involved with Morphoea, but might be more generalized as well. So, and sometimes it's at a joint which is distant to the Morphoea. In head and neck disease, particularly, we see oral and dental involvement. So you might get malalignment of the teeth. Sometimes, again, most often in childhood onset disease, if it's not picked up early, you can get some changes to the tongue, and it can be a bit asymmetrical. and some patients do get problems with their temporomandibular joint. So the joint here clicks and can be quite painful, and sometimes can even be damaged. And if the morphea happens to involve that area, you can get damage to the bones. Ophthalmological, so eye problems, so that can be linked to loss of soft tissues and changes to the muscles around and behind the eyes, and sometimes it's actually changes within the eye itself. So that brings me nicely onto extracutaneous manifestations. So whereas we have traditionally said that morphea is a purely skin-limited disease, i.e. skin and underlying structures, increasingly over the last probably 15, definitely 10 years, we have started to identify, as larger cohorts of patients with morphea have been collected, we've started to realize that you can get other manifestations, so other involvement. You do not get, as I've mentioned before, the kind of really potentially life-threatening lung, heart and kidney problems that patients with systemic sclerosis get. But in morphea, we do see some other problems. And so those are ocular, as I was just mentioning. So you can get inflammation in the eye, known as uveitis. And in children particularly, this is asymptomatic quite often. And so there are no obvious signs. So the patient does not have any pain or disturbed vision. And so unless you check for this, you might miss it. So it's important to have an ophthalmology opinion if you have linear morphea of the head and neck. And that should happen certainly as a baseline and probably 6 monthly in the early stages. There are some other changes as well, but uveitis and episcleritis are the two commonest. And then, as I mentioned, periocular muscle involvement, which can affect vision sometimes. So people can sometimes get double vision at the extremes of vision. So when they're looking to one side, particularly. Musculoskeletal changes again. So I've mentioned that we can get this inflammatory arthritis, which is not necessarily involving joints at the sites of your morphea. Generalized synovitis, so an inflammation of the synovium, which can be widespread. That should read sacroiliitis rather than scaroiliitis. So inflammation around the sacroiliac joints around the lower back. And then there is also the problem of potential damage to underlying joints. Neurologic, if you have head and neck linear disease, the commonest neurologic manifestations, which can, the numbers of patients who present with these sorts of manifestations was thought to be up to a quarter only 5 years ago, but now we think that probably between 40 and 75% of patients have some of these extracutaneous manifestations. And in terms of neurologic complications, migraine and epilepsy certainly migraine and headaches are very common. Epilepsy is a little bit less so, and the others are much less so. So focal neurological deficits, movement problems, and inflammation in blood vessels and nerves can occur. And so we, as a routine baseline, always do an MRI of the brain and craniofacial soft tissues in patients with morphea that involves the head and neck. The difficulty is that at least half the patients who have changes on their MRI are completely asymptomatic, i.e. they don't have any symptoms, but they do have some changes. And it's difficult to know whether those changes are important and relevant. Sometimes they may be, and certainly we would always involve a neurologist if we identified anything that wasn't quite right on a scan. The other thing to say is that obviously we would monitor those changes if there were any going forward. Mucocutaneous involvement. So the oral changes I've mentioned already, and then genital lichen sclerosis. So lichen sclerosis is another autoimmune condition, which by some is felt to be a sort of superficial form of Morphoea, and by others is felt to be an independent condition. So I will show you some pictures for that in the not too distant future. There are other associated autoimmune diseases. So this is felt to be an autoimmune disease, and I haven't talked about why Morphoea happens, and we don't know exactly why Morphoea happens. We're still working on that. But we know that there are certain genetic associations, so certain HLA subtypes, for instance, are associated with autoimmunity generally and with an increased prevalence of Morphoea in particular. Other associated autoimmune diseases occur probably in about 30% of adults with Morphoea and perhaps 5% of children, but then autoimmune disease is less common in children anyway, and it tends to appear as you get older. So autoimmune thyroid disease is by far the commonest association, but diabetes, type 1 diabetes, rheumatoid arthritis and lupus, vitiligo, alopecia areata, psoriasis, and lichen sclerosis, which I'll keep going back to. Autoantibodies. So in systemic sclerosis, there are some very specific autoantibodies that are recognized as associated with the disease per se, but also with particular sort of subtypes and disease complications, if you like. So for instance, SCL70 or anti-topoisomerase is associated with severe disease and more likely to be associated with pulmonary fibrosis. RNA polymerase antibodies are more likely to be associated. All patients are at higher risk of renal crisis. So there are some well-defined antibodies, and they have associations and prognostic implications. In Morphoea, that's not thus far been found to be the case, although there are some studies which are beginning to show that perhaps autoantibodies are a bit more important than we realized, but that is still quite new and evolving. But if we look at just a standard ANA, anti-nuclear antibody, which is a very broad measure of autoimmunity, and it's a non-specific antibody. It's positive in systemic sclerosis, it's positive in lupus, it's positive in a whole host of dermatomyositis, lots of different autoimmune conditions. And ANA positivity is documented in a significant number of patients with Morphoea, and probably at least 40%, and in some studies up to 80%, but it's probably 40% is a good benchmark, I'd say. And it was thought always to be associated with more severe deep disease, and then subsequent studies suggested that it could occur in any form of disease, and then more recently it's been associated with a higher risk of relapse. So patients who have a positive ANA may be more likely to get relapsing disease going forward. Very few patients have the same systemic sclerosis specific antibodies, but a small proportion do, and that doesn't necessarily mean, and it's in fact in a majority of cases, it doesn't mean that those patients are going to go on and develop systemic sclerosis. So the role for those antibodies in that group of patients is not really clear. And then there are a number of antibodies that are particularly recognized in patients with Morphoea, and those are antihistone, anti-single-stranded DNA, and anti-topoisomerase 2, which is different to the one associated with systemic sclerosis. And these are not done routinely, but there is a little bit of information that suggests that they may be associated with particular patterns of disease. So going forward, that may change.
I'm so sorry to interrupt, Kate.
Yep.
Can I just give you 5 minutes to wrap up so we have some time for some questions?
You certainly can. Okay.
Thank you.
Okay. So lichen sclerosis. So this is this condition I keep talking about. So this is a condition which tends to happen. So most frequently we see lichen sclerosis overlapping with Morphoea. You get this shiny white, sometimes cigarette papery sort of scale on the skin. And it can happen on top of Morphoea plaques, or it can happen separately. But in this group of patients, as I say, predominantly middle-aged ladies, it's really important to consider the possibility that they may have also genital lichen sclerosis, because this is a condition that can involve the vulva. Sometimes it's very itchy when it does that, and sometimes not at all and completely asymptomatic, but it does lead to architectural changes. So it damages the architecture of the genital area. And there is a very small, so it's roughly 5% risk of developing squamous cell carcinoma, so a type of skin cancer in vulval lichen sclerosis over a period of years. So it's a small risk over when in patients who've had it for a long period of time, but it is important to pick it up. And treatment does seem to reduce the risk of malignancy. So in patients who have widespread disseminated plaque morphea, we always recommend that they have a vulval check, either at their GP or with us. I'm just going to briefly talk about eosinophilic fasciitis, which is, so this is a lady who presented with really sort of sudden onset of swelling of her limbs, as you can see, but her fingers were really spared. The swelling was distal. The important negatives were that she didn't have any evidence of Raynaud's palpitations, the sort of signs of systemic sclerosis. She had an eosinophilia, which is a common feature in bad morphea. Her ANA was negative and her other investigations were normal, but she had a biopsy and an MRI which confirmed that she had fasciitis, i.e. inflammation going deep and around the muscles and fascia. So she was treated with methylprednisolone, steroids and methotrexate. And she did really well in that her swelling and the skin thickening reduced, but she then developed plaque morphea, which gradually faded and resolved with her treatment. So she was on methotrexate for about 2 years and then came off it during COVID and has actually remained very well. So eosinophilic fasciitis and pansclerotic morphea are both circumferential. They can both start on the limbs or the trunk. Fasciitis is said to most commonly happen on the limbs, and pansclerotic morphea starting on the trunk. But they're really, in my opinion, pretty interchangeable. So I think we need to just kind of consider them as two ends of a spectrum. The important thing is that that they're picked up early and treated early. So in terms of investigations, I'm going to fly through this, but really you don't have to do any investigations. It is a clinical diagnosis, but we often do a few blood tests. And if there's any question about depth of involvement, we will do a skin biopsy and or an MRI to assess depth. What represents active disease? So new lesions, extending lesions, that red border, increase in skin temperature, and then evidence on an MRI of inflammation, evidence of progression on clinical photographs, and also we use something called the LOSCAT, which is a skin score which allows us to assess activity and damage. And we could follow that, and that the development of that by Cate Orteu's group was really pivotal in our ability to assess outcomes of treatment in patients with morphea. We can do serial thermography, which can be helpful, but is not a perfect tool. This is a chap with linear morphea involving that paramedian forehead, and you can see that it is hotter and redder at the site, and that can reflect inflammation. Sometimes it also just reflects atrophy and tissue loss, so the vessels and the heat from the vessels is more easily able to come to the skin surface. So it's a little bit difficult to interpret, but can be helpful. And then MRIs, as I mentioned, so edema and inflammation in the skin and in the fascia around muscles. We can use MRI to do 3D reconstruction. So this is a chap who's got involvement. You can see that he's got some soft tissue loss around here and also around the chin. And so we can use these to sort of follow things serially. And what are the outcomes? Well, we know that actually patients, a significant number of patients with morphea, particularly linear morphea and onset in childhood, have either chronically active or relapsing remitting disease. And that can be whether or not they have been treated. So even post-treatment, there is a risk of relapse. So we not infrequently see patients who have been diagnosed in childhood and treated at Great Ormond Street, in my case, and then who come back later on in life with a subsequent flare of their disease. So this can happen, and it's important, therefore, that you know, we keep patients on our books for quite a long time, at least 5 years after their disease has settled down, and sometimes longer. So the important thing in terms of how we decide how to treat people is it should be based on whether the disease is active, whether it's deep, and how extensive it is, and therefore what the risk of complications and tissue damage is, and how much of an impact it's having on the person, of course, which is clearly crucial. This is a slide of piemontidase from a study that was published in 2012 from the US. And this just showed that, you know, if you saw a dermatologist, you were much more likely to be treated with topical steroids than if you saw a rheumatologist first off. If you saw a rheumatologist, you were much more likely to be treated with systemic, i.e. intravenous steroids and methotrexate. So this is clearly not ideal, and despite quite a lot of teaching and increasing awareness, there was another study in 2018 which showed very similar things. So it shouldn't depend on who you see as to what sort of treatment you get. It should depend on the type of morphea that you have. There are some minimum standards of care now that have been published for juvenile localized scleroderma, and I would recommend this publication in that respect, which sort of outlines the need for regular assessments, baseline MRIs, ophthalmic assessments, dental assessments, and you know, when to treat, really. So again, activity, depth, extent, risk of complications. Everybody needs psychological support. Most people need some physiotherapy, and manual lymphatic drainage massage is often very helpful. The topical treatments, so cream treatments, are first-line treatments if you have mild disease. So if you've got limited plaque disease or superficial plaque disease, even if it's a little bit more extensive. If it starts to become more generalized, and so those patients with disseminated plaque disease, if it's superficial, then you would add in light treatment, and UVA1 phototherapy is the most effective. Narrowband UVB is the next best available. UVA1 is not very available in the UK. In London, it's available at Guy's and St Thomas's. There is some in Dundee, there is some in Newcastle, and I don't think there is any UVA1 elsewhere. So most people don't get UVA1 in the UK. Moderate severity disease, we would go with topicals and phototherapy first line, and then second line would be hydroxychloroquine, and this is an anti-malarial drug which has been used for donkey's years for all sorts of different indications, including rheumatoid arthritis, lupus, and now morphea. So there's one interesting publication from the Mayo in 100 patients, of whom 40% cleared, 40% improved significantly, with over 50% clearance. But it takes a while to work. So it takes probably mean time to onset of action was 5 months. And really you need to be on it for 18 months to see maximum benefit, really. And then in more severe disease, the mainstay of treatment is methotrexate and steroids. Mycophenolate is the next best if you don't tolerate methotrexate or don't respond to it. And then now, Voon Ong and I worked with the rheumatology commissioning group, or clinical reference group for NHS England a couple of years ago, and we got abatacept for the treatment of severe treatment-resistant morphea in adults and children over 2. So that's our kind of go-to in really severe disease and or in patients who haven't responded to previous treatments. And so it's really for disease crossing joints, limiting mobility, multiple body sites and deeper structures, and people who have got significant functional impairment or who haven't tolerated or responded to previous drugs. On the horizon, tocilizumab, which is being used in systemic sclerosis and is certainly FDA approved for that in the US. I don't think it's been approved yet here, and it certainly isn't approved for children or adults with morphea, but there are some publications, and hopefully that will be something that we are able to access in the not too distant future. And then there's a group of drugs called Janus kinase inhibitors, or JAK inhibitors for short, and tofacitinib is one of them, and that is being used. There's a topical preparation of JAK inhibitors, so a cream, which has been developed, and there is also a little bit of data on systemic use. And then finally, rituximab. There's less evidence. There's a lot of evidence for rituximab use in systemic sclerosis, and rituximab basically blocks your B cells and stops you making antibodies. So in systemic sclerosis, that makes sense because we think that antibodies are really important in pathogenesis, certainly in some types. But in Morphoea, that is still up for grabs. And so the impact of rituximab in Morphoea, I think, is, well, there isn't enough evidence at present. And I think it is still uncertain. How do we assess treatment efficacy? Serial MRI is useful, and those are the clinical, and we use the loss cat, that score that I was showing you to assess that. And then in an active disease, there are various things that can be done. So fat transfer is really helpful, particularly for head and neck disease. If you have a forehead with a groove, fat transfer can be really useful. And then we involve lots of other subspecialties, as you can see there, to help. Right, so a rather rapid flick through the last bit, but I hope that was helpful, and I'm here to answer questions.
Thank you so much, Kate. That was really, really informative. I definitely learned a lot. Yeah, so let's blitz through some questions if we can. Kate has also offered to answer any appropriate questions that we don't get to over email through me. So do contact me afterwards if there's something you feel like wasn't addressed. So we have a question, first of all, that mentions a lot of kind of personal stuff that I'm sorry, I will pass over, but I'll get to the crux of your question, which is great. That says, what do you recommend I do to slow down the spread until my first appointment mid-December? Does a change in diet, for example, work? If so, what diet would you recommend to follow?
That's a good question. I think so. There's not a great deal of data on diet in Morphoea. There is increasing amounts of data on the gut microbiome and a link between gut and skin microbiota. And there's also, I think reading about the gut microbiome can be helpful, and thinking about what you're putting, raw foods as opposed to processed foods, because we know that lots of processed foods can be pro-inflammatory. I would recommend Tim Spector's books actually on this, because I think he has written some very helpful things. He's a fountain of knowledge when it comes to microbiome. There's some data that suggests that celiac disease, or there's a few case reports of celiac disease and Morphoea being associated. So in some situations there are patients who cut out gluten, and so if you are gluten sensitive and you eat gluten, then that is pro-inflammatory, and so any inflammatory underlying condition will be made worse potentially. So I guess you can always try removing gluten from your diet. It may not help, as I say, there's no massive data, but there are some cases, and those patients have associated autoimmune diseases. So there is this theory that if you have a background predisposition to autoimmune disease, then they may kind of interact and not feed off each other, but if there's inflammation being generated by one problem, then it can potentially feed into the other.
Shall we
Yep, go for it. Sorry.
It's okay.
Just one other thing is just to make sure your vitamin D is tip top. That's important too.
Great. Is Morphoea, generalized deep, associated with fatigue?
Yes, often. So I think the part of those extracutaneous manifestations they include fatigue, arthralgia, and in a group of patients we see those tend to go together. So you get kind of achy joints and just feel exhausted, and that's, yeah, I see lots of patients who come in early on in their disease course, or when it's inflamed, and I think it's a feature of inflammatory disease generally, actually. if you've got really bad inflamed psoriasis, I think it makes you feel exhausted too. So I think it's a feature of the underlying inflammation.
Great. What's your opinion on the links between flare-up and trauma?
Good question. There's data in the literature about trauma triggering morphea, and that trauma can be, so there's various publications on, so bigger studies on trauma from injury, so car accidents and it's physical trauma. There is association with stress. So in the 6 months prior to the onset of your morphea, trauma can be psychological and or physical. Sometimes it's surgical. There are quite a lot of case reports of immunizations triggering morphea. We have certainly seen quite a bit of morphea either new or flaring in relation to COVID and COVID vaccination. So I think, that vaccination generally, hepatitis B vaccines have also been associated. And then there are a few drugs which are associated with triggering morphea as well.
Okay, great. One more very brief one to finish off, and then the rest of them, thank you so much for sending in your questions. I'll try and pass them on to Kate afterwards. So one last one. We all know that sunbathing is bad for you, but is it especially bad for those with morphea?
Well, in as much as light treatment is used in morphea and can be beneficial, no, sun exposure is okay. But if you are on systemic treatment, so things like mycophenolate increase your risk of getting skin cancer. Methotrexate probably does, but to a lesser degree. But suppressing your immune system is not good for your skin cancer risk. So you need to. It's a balance basically. So it depends on. You have to be taken as a case by case on an individual basis, really. Would be my thought. And I mean, I'm available for another 5 minutes if you want to carry on. That's fine by me. If you can't, that's also fine.
I think we're limited on the Zoom channel, but thank you so much, and thank you everyone for attending and your amazing questions. We'll definitely try and make sure that they're answered. It's just a shame they can't be answered today, but thank you so much for your talk. It was wonderful.
Thank you. Thank you very much for having me.
Not a problem. All right. Thank you everyone for coming, and we'll see you at the next webinar. All right. Bye.
Bye.